You're seeing the PPT, right?
Yeah, section 9.
Yeah.
Okay. So what I planned for today is section 6 and section 9 together. I think in total 85, but towards the last it is activities. So maybe 80 slides. I think we can finish it because most of it, these portions you have studied already. So the protozoal parasitic diseases, everything out there. So it's just a brushing up, we can say, in this section. And preventive medicine, I started with preventive medicine because here we say about the common methods by which the diseases are spread. The respiratory route, by contact, by touching, or using any fomites. So what are the different ways? The fecal-oral route, sexually transmitted ways. So that is what section 9, the first part, is discussing about, and how we can do the prevention, the prophylaxis vaccination. And I told you in one of the introductory class, PSM or SPM, infectious diseases. And when we do have homeo prophylaxis, but still there is nothing. When there is an infectious disease we are speaking about in preventive medicine, we can't conclude that thing without mentioning the related vaccination. Vaccination is an important part when it comes to infectious diseases and preventive medicine. So that is the first section of the section 9. And because there were the introduction being given, I put section 9 at first, and then we go to condition wise. So section 6 we will deal after to that. Then section 10, it is about some common bacterial and viral diseases, I think. 10 and 11, and 12 is NCD. That is how it goes, I think. Then in preventive medicine, that is section 9 itself, there is a second part of it, which is dealing with mental health services, mental health, then school health services, and also maternity and child health services. So I have arranged actually earlier with one lecturer in the nursing department to do that classes for you. But I'm not sure because she has gone for a surgery, for her own surgery. So I'm not sure when she will be back. By the time I finish this section 6, 9, 10, 11, and 12, even then she is not returning. Then I will be taking that portion of section 9. We'll wait until then. By that time, whether she is coming back or not. Okay, so starting with section 9. So here we will be studying the objectives about the communicable diseases, different means of communicability, and the principles of prevention. And also about the protozoal and helminthic diseases. But as like in PM, when we did the parasitology, we have done a lot of parasitic diseases. But here we are not going into much of the this in this syllabus. There are no much parasitology that you have to cover. Solely a few, 4 or 5 we are doing. And malaria, filaria, I think it comes in section 10 or 11. So yeah, as I told, we are going to study about the diseases that are spread by contact, the most common by droplet infection, and the other environmental vehicles, and also prophylaxis and vaccination. So, what are communicable diseases? Now that you know, communicable diseases are also called as infectious diseases because they can be communicated from one person to another, or in other words, it can be transported from one person to another. And these are diseases usually caused by bacteria, virus, fungi, or parasites. And when transmitted, it can be transmitted from one person to another, or the zoonotic diseases, that is from animal to human beings, or through environmental sources like food, water, soil, etc. It can occur through direct contact by respiratory droplets, contaminated food or water, vectors like mosquitoes, or even zoonotic. Zoonotic can be any animal via also. Vectors, it is usually about the invertebrates, the insects, mosquitoes, flies, that we are mentioning about. But in zoonotic, like the rabies, when it is coming from even the vertebrate organism, we call those diseases as zoonotic diseases. So, what is the impact of infectious diseases? So, communicable diseases on global health. It has got a profound impact because this is going to affect the mortality and morbidity, and in a way that is going to affect the social and economical development of the country, uh, particularly in low resource settings. So why? What is the importance of understanding this communicability? It is more epidemiologically related. So when we do, why we have to study this is when we why we study this is because of the reasons that we told, the mortality and the morbidity and the socio-economical situation of the country. But how we are going to understand what is the features of these diseases or its communicability or transmission. For that, we need to know about the epidemiology. And in epidemiology, you might be learning about when we did the epidemiology. At that time, we have told you in epidemiological studies, what we are going to do is every WH questions like what, when, how, why, who. These are the questions that they will be dealing in epidemiology, like what is the disease, how it was spread, or how it was initially broke out in the society, who were the people, what were the age group that was more commonly or most severely affected, and how it was transmitted from one person to another. So all those patterns that will be discovered. Oh yeah, that will be they will be studying about it, and when they are learning those things, they will understand when these questions are being answered. They will get into the risk factors also, or the causative factors. What led to the breakout of this disease? That will give what are the risk factors, and also if any age or particular sex is more exposed to this kind of diseases. So by epidemiology they will understand the risk factors also, and then when they get answers for all these, the risk factors and the patterns how the disease are spreading, they will know how to prevent it. Now in epidemiology itself, one of the important concept we learned in epidemiology was the epidemiological triad, if you remember that triangle. So we have the agent factor, we have the host factor, we have the environmental factor. And in that class itself, I have told you, we learn all these things or the triad in proper, so that in preventive medicine or in epidemiology, if we are able to cut that transmission in that three lines, we don't have to make a break in all the three lines in that triad. The most important line or that connection, that transmission, if it is between agent and host, making a break between that, or any of those three we do, we can cut off that transmission. So we have to first make that triad. For that epidemiology is required, and then when we make the necessary disconnection between any of those lines or all of those lines, but all of those is not necessary. The most important transmission line, that if we are able to understand that, then we can do for the prevention and control. And in case an outbreak is coming, then what to do, how to respond to that. So these all things we learn when we do epidemiology. And its importance in case in public health is, it is very essential, not only for the researchers and academics, which mean the epidemiologists, epidemiologists who are in the research, but it is also important for the healthcare providers, that is the hospitals, the professionals, the doctors, and also the policy makers, who are people in the government, and releasing the policy regarded. By having a grasp of these communicability principles, the stakeholders, people whoever is involved, they can take informed decision and can protect the public health and also effectively manage that disease transmission. So now different modes of transmission. So first one will deal with the contact transmission by contact, and this contact transmission can happen in two ways: the direct and the indirect. Direct is when you are going to touch the patient or direct contact has been happening. That will be the direct contact manner. So it is either through physical touch or exchange of body fluids or contact with contaminated surfaces. But this contact with contaminated surfaces, when the patient has touched somewhere, and then if we are going to immediately touch that area, that is contact itself, but a kind of indirect contact the transmission will be. So direct will be with the direct touch with the patient or the exchange of body fluids, and if it is the touching on the contaminated surface or using of any formats, all the things that the patients were using, that will result in indirect contact. So common examples will be skin to skin contact, scabies, and impetigo. Sexually transmitted infection, it will be HIV, syphilis, gonorrhea. And format transmission, influenza, common cold, conjunctivitis. And this influenza common cold can also be transmitted via respiratory droplets. So the second type of transmission will be the respiratory droplet transmission. So when the person is actually when talking, coughing, or sneezing, via that liquid which is coming out, the virus or the bacteria may also be there, and it will be suspended in the air for some time. And a person is exposed to that, can have the infection. So respiratory droplet in transmission occur when the infected person release small liquid particles, especially when the person is coughing, sneezing, or talking, and they travel very short distances and will be remaining suspended for some time only, not for a very long time. And very long time, if it is happening, it may settle down on the ground, some kind of virus or bacteria, and then if it is more dusty area and on the floor, and if someone is going to clean that dusty area, even that inhalation can produce the infection. And some notable examples are influenza, COVID-19, and tuberculosis, which is caused by mycobacterium. The another common is fecal-oral transmission. That means the feces that is being not properly disposed, or open defecation. Now that we have done with the different type of sanitary latrines, and also the open type, you now know whether if it is not properly disposed, or even the sewage. When the sewage is not properly treated, and if it is being dumped in the water, you know how now that can get transmitted. And the flies, they are also the mechanical potters. We learned that it is actually flying in between the food and also the feces. So the fecal oral transmission, that is the third important one. So here the infectious agents are spread from the feces of infected person to the mouth of a susceptible individual. It can be bacteria, virus, or parasites. And parasites, mostly our worms will be coming under. The cyst over of the parasites will be defecated, or it will be expelled from the body via the stool. And in case of bacteria, the best example will be Salmonella typhi and also the cholera. Then this transmission route often occurs when there is contamination of food, water, or any surface with fecal matter which contains the pathogen. This mode of transmission is particularly common in area where there is poor sanitation, where open defecation is very common. And when in a society open defecation is happening, still now means can be out of practice also, but that will be confined within a small group of people, like very old age, that they can't change their habits. But mostly we are not never going to see people defecating openly, and if that is happening, it shows the poor economic development of that country also, and also the poor sanitation practices. So diseases transmitted through fecal oral route will be the most commonly hepatitis A, which is affecting the liver, and it is mostly due to the contaminated food and water. Other one is cholera by Vibrio cholerae. Now, vector-borne transmission, where the insects are involved. like the blood feeding arthropods such as mosquitoes, ticks, or fleas. That will be their bite. They will be transmitting the diseases between two organisms. Um, these vectors act as the carriers of the infectious agents. So it is not the vector is carrying the organism. Oh, yeah, it is carrying the organism. It is not within the vector the organism developed. The vector may be biting some other animal from which this particular organism will enter into the vector to that insect, and then the insect somehow come into contact with the human being. They are biting, then this organism will enter to the human body. So most important from other common example is malaria, which is transmitted by the Anopheles mosquito, and the infectious organism which causes malaria is the Plasmodium parasites, all the Plasmodium vivax, malaria, falciparum. Um, then there is something with O also, Plasmodium vivax, malaria, falciparum. This is one Plasmodium with O. Suddenly forgot. Which is one Plasmodium? Plasmodium vivax. Ovale. Plasmodium ovale. Plasmodium ovale, Plasmodium vivax, Plasmodium malariae, and Plasmodium falciparum. Those are the four varieties of Plasmodium. And dengue fever, which is transmitted by Aedes mosquito, which is caused by the dengue virus. Just kept a picture. The zoonotic transmission, which is transmitted from animals, which are the vertebrate animals to the humans. So it can be direct contact with the infected animals, especially the veterinarians or people who are rearing some domestic animals, direct contact with them, or consumption of contaminated animal products, like even Mycobacterium tuberculosis. Tuberculosis can be spread by if we are going to drink the milk of the cow which is having TB, or that milk if it is not pasteurized and the milk is having the presence of mycobacterium, it can result in tuberculosis in case of human beings. So contaminated animal products, via that we may get the zoonotic transmission, and contaminated animal products resulting another common disease is brucellosis. Then the third way of this one is exposure to animal habitat, like human beings going into uh, certain forest, I mean deep into the forest for poaching and all, and then they are getting exposed to this wild habitat, then they can result or some diseases may be spread from them. So it is also called as the term over there. It is also called as zoonotic spillover. Like if the person had not, or human beings have not gone into those particular forest or jungle area, it wouldn't have spread into the common or the people where the people are residing. It might be a transmission that is happening within these wild animals only, but the moment when the person uh, go into this wild um, habitat and he get exposed to any kind of bacteria or virus. Ebola virus was some a disease that got transmitted like that. So people go into that wild habitat and then they get exposed, and then when they come to the human habitat or our mean, where we are inhabiting, the disease is getting transmitted. So these are the three different ways by which the diseases from the wild animals or animals, not just wild, even the domestic animals can result in that. So that's how we get the disease. The most important one is COVID-19. COVID-19, though it got transmitted by respiratory droplets, when we go for the origin, we always believe that it was first, we always tend to believe whatever, it was first I mean, not transmitted. It was first. I mean, yeah, they have used the thing. Yeah, it was originated from bats, like from a wet market actually. That's how they explain the Wuhan wet market. The meat was exposed, and then the people got the disease. That's how. Then it was respiratory droplets or the respiratory transmission that happened. So COVID-19 is believed to be originated as a zoonotic disease. Even Nipah is considered because it also originated from bats. Um, and this bat that ate some fruits, and when the person was having these fruits bitten by that infected bat, he got the infection of Nipah. So that is also considered as a zoonotic disease. The first case they got like that. Then from person to person, it was transmitted mainly by the droplet. Rabies is another one, uh, transmitted to human through the bite of dogs, bats, or raccoons. And Ebola transmitted from fruit bats, especially Theropodidae family, through blood, secretions, or other body fluids. So the emerging zoonotic disease, whatever I told now, so we'll come the examples and the route by which it came. SARS-CoV-19 avian influenza from the wet market, the wildlife hunting or wildlife poaching, which resulted in HIV and Ebola, from the domestic animals, from their rearing something, it resulted Nipah, avian influenza, and Hindra. Um, Rabies, COVID-19 is also from this intensive wildlife farming. Now, the blood-borne transmission. Blood-borne transmission is via the needle sharing, blood transfusion, or organ transplantation. The best examples will be HBV, HCV, and HIV. Vertical transmission, that is from mother to child, and that can usually happen during pregnancy period or during the process of childbirth or via breastfeeding. The best example will be HIV and syphilis. So that are the common ways how the communicable diseases are spread via contact, that can be direct and indirect, and then via the respiratory droplets, via fecal oral route, then vector borne, then the zoonotic diseases, then it was blood borne, and lastly the vertical transmission or MCT, mother to child transmission. Now, after learning the mode of transmission, we go what are the ways, because it is SPM. Rather than treating, we have to mention about the ways of prevention. And when we say ways of prevention, we now need to remember the second chapter where we have dealt with different types of prevention. There is primary, secondary, tertiary. Yeah, and then it was initially that primary, secondary, and tertiary, and then they added a new one that was called as the primordial prevention. And to prepare today, I was just googling, because every time I do, even though I have the PPT ready, I will be just googling just to know whether there is anything new that came up. So last week when I was searching in one of the article, I saw this one, quaternary prevention. Even I had not heard that thing. It is not that much new and all, not just it came up last week, nothing like that. But even I heard only in that research article. So I put that also. So it is actually primary, secondary, and tertiary that is important. But nevertheless, primordial is also important, and quaternary, the researchers say it should also be given importance for the prevention. So we will go to different levels of prevention, but whomever there is, just be a bit active. Before we go into, do you remember what is a primordial prevention? Primordial or primordial prevention? Anyone who is remembering?
This one, uh, is it at the very beginning when the person is still healthy?
When person is
Before the disease, before the disease.
not before the disease, even before the
Preventing
risk factors.
preventing
Even
or can I say preventing the development of risk factors and behavior.
yes, yes. Even before the development of risk factors. So always, I say you that when the MCQ comes, it is very confusing because secondary, tertiary, and even quaternary we can differentiate. Even though this quaternary is a new concept, so even that is that we can differentiate. Always the confusion will be between primordial and primary. What you put, the example will be like that. So the important or a single most way to differentiate that is you need to find out whether there is a risk factor present or not. If the risk factor is absent, it has not yet developed, and some activities are done so that these risk factors, even that doesn't develop, then it is a primordial prevention. Like in case of mostly it will be health promotion things that is done during that. So one of the best example will be in case of kindergarten children, so primary school children. When we are educating them that they shouldn't go and eat all these junk foods or become potato coach, or no, sorry, coach potato, or even have these unhealthy snacks or drinks or ice creams. Uh, and that means very, very, very less. Uh, the kindergarten babies itself should be told so that they don't get into obesity. But if we go to a little more like second standard on, maybe then the child will be exposed to all these things. So then it will go towards the primary prevention. So we need to differentiate whether the risk factors develop there or not. If it is not at all there, and then the prevention is taking place, that is primordial, where we are trying to do the health promotion, like health education plus some policy changes, and also making a behavioral change. And in primary prevention there are risk factors, and we are trying to minimize those risk factors and prevent the disease from appearing. And secondary it will be the disease is there, so we are trying to find out early detection, early detection and treatment, that will come under secondary. And tertiary it is to prevent the complications. So rehabilitation, such activities comes under tertiary. And quaternary is more like not to give over medication or over treatment, or not make the patient overly exposed to any kind of treatment. So the primordial prevention, the focus will be to prevent the development of risk factors even. And this is usually happening at the population level. Entire community or societies are the focus of primordial prevention. So the strategies that is being utilized over there will be health promotion, like promoting healthy lifestyle, nutrition, physical activity from an early age to prevent the emergence of risk factors. So if a person in 20s is going for a gym, we can never say that it could be a primordial prevention, um, depending whether he had been exposed to the risk factors. Like if he is practicing a healthy lifestyle, no smoking, no alcohol, not even junk foods, then yes, because the risk factors has not developed, but that is usually in the individual level. But if we are saying some school children to do these things without even getting exposed, then that is also a primordial type. But then we are targeting a group of students, not in the individual basis. But if we see about a person in 20s something who is already an obese person, and then he wants to reduce his body weight for aesthetic reasons or healthy reasons, then it is not a primordial because he already had developed all the risk factors. He was eating all the junk foods, he was not exercising, and then if he wants to do something related to that, The risk factors have developed, so it is no more primordial. So the examples are so closely attached. We need to actually find out whether there is a risk factor present or not between the primordial and the primary prevention. Then here, health policy is very important that create environments conducive to health, such as urban planning that encourages physical activity or regulations promoting a healthy diet, like imposing taxation on a high fat diet, uh, and that also this one urban planning. If they are creating spaces, the parks, etc., where the people can do certain exercise, or what is that? Mm, the cycling area. There is a path for the cyclists or the bikers to go. So that is promoting um, walking in the society or within the community. So that urban planning, infrastructure planning also will come under the primordial prevention. So the example is promote a healthy food environment and physical activity in schools to prevent the development of obesity in children. Because obesity could be a risk factor for many diseases, the cardiovascular disease, then what? Obesity, yeah, cardiovascular, everything will come, heart disease, stroke, diabetes. Yeah, the everything we can prevent if this obesity itself is not being developed in children. Then primary, here it aims to prevent the onset of diseases either by eliminating or reducing risk factors, which means here the risk factors are already present and we are trying either to reduce it, those risk factors, or to eliminate it. So we will be targeting the family or the community in which the risk factors are there. So earlier, if we were giving, in case of primordial prevention, if we were giving classes or health education classes to the kindergarten children, in primary prevention, we may be giving the classes to a little bit or little more senior students, like maybe from uh, 8th standard, I don't know in your classification where it comes, the higher secondary school. So some of them, not all, but some of them may be already exposed to smoking, a few due to peer pressure. Not all the children in that class, but one or two might be. So, though we are doing actually the primary prevention. So though we are using actually the primary prevention, where we go and target that particular community. And maybe also if we are going towards we find out a group of community where the people are more exposed to smoking, the college students and all. We are going that uh, targeted population or where the risk factor is already developed, then it is a primary prevention. So health education comes here also, such as smoking cessation programs. So in primordial, we were advocating the small kids never to start even smoking, so that this risk factors are not developing in them. But here, we will be targeting those population or that section of population in which they might have already got exposed to smoking, and then we are asking them to stop smoking. Then the another example, like it will be usually for the MCQ, it comes when there is immunization. So you can also remember it like where the policy is coming, when the policy is being advocated. So if the MCQ, when it comes, it is mentioning about the policy, or if it is mentioning about the urban planning, urban infrastructure, where the persons have to move about or something, it will be primordial. And here usually the confusing will be the immunization. They might ask like any they not be asking particularly or just saying generally immunization. They may be saying that giving measles vaccine, uh, whether it is coming under which type of prevention. So immunization, if you see that word immunization, mostly it will be coming under primary prevention, because the person has got already the risk factor is present, and we have to either reduce it or eliminate it. So immunizations will always be coming under primary prevention. Um, so childhood vaccination prevent diseases like measles, mumps, and rubella comes under primary prevention. Now, this one, after the immunization that is happening after the person have got developed the disease, not disease, after developing, no chance, because there also, if it happens, if we are going to give immunoglobulins, then also the person has got uh, risk factor. But if it is given in the form of a treatment, any injection that is being given in the form of treatment, then it will change towards the secondary prevention. We have to be careful over the which disease, like after exposure to rabies. But after exposure also the risk factor came up, it is not a treatment, it will be more like a prophylaxis. um, but any vaccine or injection that is being given, now I'm not getting any example if something's spotting out, but the question, you'll have to be careful whether that injection is given as a part of a treatment. If it is coming under part of a treatment, that will go towards the secondary prevention. Otherwise, it will be immunization will be always related to primary prevention. Now, why I'm repeating this is the questions coming from here, the MCQs can make you confused. Even now, when I also formulate, I don't put that much difficult for you, but sometimes I see some of you making it correct, but some of you making it confused or making it wrong. So these are the some techniques by which you can differentiate which category does it belong to. The secondary is to detect and treat diseases in their early stages. So when we are going to do the screening, the best example over here will be screening. When we go to the population and when we are going doing a screening, like even when we are checking the pressure of a group of people, or we are going to check the blood sugar of a group of people, it is kind of we are finding out the people whether they have the disease or not, whether they are having hypertension, diabetes, or similar conditions. So any screening method that comes under the secondary prevention. Always remember, urban planning policy, that is under primordial, that will be the most easy one to solve most of the MCQs. Then in primary it will be usually immunization. Only when this immunization or injection is given as a part of the treatment, then it becomes a secondary type. Otherwise immunization is mostly in the primary category, and in the secondary it will be early detection and treatment. So screening comes under this secondary prevention. Then health education, it can come under primordial and also primary, but over here secondary tertiary health education rarely comes. So early intervention, that also comes over here, because it is about intervention is about interfering, or we are going to treat the condition. So in secondary, it is detection or diagnosis and treatment. So any example which is indicating towards the diagnosis of the condition or the early treatment, then it will be the secondary prevention. So some examples which is being asked, mammogram if it is done, or pap smear. Pap smear, it is for the recognizing or detecting cervical cancer. So any screening diseases they are mentioning, it will be indicating towards secondary prevention. Tertiary, this is the most easy to find out, to prevent complications, disabilities, etc. So the person is already having that disease, and it will be mostly a crippling disease that we are mentioning, so that they don't go into much more complications, like a patient who is having leprosy. So he may go into a crippled stage. So we need to do some rehab treatments, that he doesn't go into complications. So all the rehab activities, it comes under the tertiary prevention. The cardiac rehab programs for individuals recovering from a heart attack comes under tertiary prevention. Now the quaternary prevention. So this is a higher level of prevention. It was suggested first by Jamo, I think that is how it is pronounced, and Ronald. So quaternary prevention is defined as action taken to identify patient at risk of over medicalization, protect him from medical invasion, and to suggest him interventions ethically acceptable. So sometimes people may be exposed to over medicines or kind of over diagnostic procedures or over treatment, and that itself can result in certain complications or any some other disease in them. So a prevention that recognize those people and then give them suggestions or some other interventions which is ethically more acceptable. So this is an evolving concept in the field of preventive medicine and public health, and it should be applied in current scenario because the basic principle of powers in preventive health should be primum non nocere or first do no harm. So because of that, we need to discover those people who were this over medicalization is not given, or if they are given, recognize those group of people and say them healthy alternative methods, which is more acceptable. So the key aspects here will be avoiding overdiagnosis, like people repeatedly doing mammogram. I think in Western countries, they have packages for women above 40s to go for a annual checkup, especially for breast cancer, as it is very prevalent over especially the mammogram. And now the researchers have found out that even too much exposure of mammogram can itself induce a breast cancer in a lady. Maybe this lady never would have had a breast cancer if she were not exposed to that much mammogram. So mammogram is actually a detecting, a diagnosing tool, and if it is overly done, that process itself can induce breast cancer in the lady. So the key principle of quaternary prevention is to avoid any method or any over diagnostic procedures, preventing over treatment, and promoting informed decision making, like let the patients know what are the risks and what are the benefits of those medical interventions, and let them make the choices according to their preferences and values. So that is more about the quaternary prevention. Now, as I told, when we say about the prevention, of course vaccination is very important. So it is one of the most powerful tool in preventing communicable diseases. And what vaccination do is, it depends like mostly they are going to inject the antigens. So antigens, when it enters into our body, our immune cells will be producing antibody against it. So that is happening in case of vaccination. The immune system produce antibodies against specific pathogens, and that provide immunity without causing the actual disease. So when baby is born and we are going to give him BCG, it is not the baby had got exposed to Mycobacterium tuberculosis when he was I mean when he took birth itself, but we are not even allowing the baby to get exposed to it. Even before that, antigen is entered. The antigen might be killed antigen or killed vaccine or a live attenuated, or the antigen might be, or the virus or the bacteria might be live but not so strong enough to produce an active disease, but still that much active that our immune cells will produce antibody against those antigen. So the actual disease doesn't come up, or in case it come up, our immune system is already ready present. I mean, they have that ready-made antibody to fight against that. You know this. We did the immunology in detail. So by vaccinating a significant portion of the population, we achieve the herd immunity, and this is very important. A group of people is getting immunized, and the best aspect of this is this will indirectly protect vulnerable individuals such as those who cannot be vaccinated due to medical reasons. So if we are going to vaccinate a large group of people, they are getting immunized. So even if a person is having a disease and someone is coming in contact with him, and the person, if that person has immunized, he is not going to transmit the disease to third person. So if a large number of people are immunized, the herd immunity, then other people will be protected. So in this manner, in this herd immunity, the other people, we don't say about the common people who can do the or who can take the vaccine, but mostly those people who are not allowed to take vaccines, like HIV people, pregnant women. Uh, so in those people, due to some medical reasons, if they are not able to be vaccinated, they are protected if for a disease there is a herd immunity. Now that can be better shown by a picture. So here you see the blue colored who are actually non-immunized people, and they are healthy, they don't have disease. But in that community, two people are coming up. See, the frequency is very less or the prevalence is very less. Only two people are infected. But because these people are not immunized, most of them are going to get infected. But when the number of the people who are getting immunized, it is comparatively increasing, then you see still there are people who are getting infected, but then in between there are some people who were immunized who are protected also. But when compared to these two pictures, you can see some people are protected here, there. But in this community, were still the number of patients there, that is only two. But most of the people are now immunized. The yellow means they are immunized or they have taken the vaccine. So even if some people are there, the blue colored one who are not immunized due to any reasons, due to medical reasons or personal reasons, whatever reasons, they are not immunized. Still, we don't have much problem because with the patient, the community that is coming in contact will be those who are immunized. So the transmission is stopping in that itself from the person. So if a community is having a herd immunity, then we can prevent the transmission or the spread of the disease in that community. So that's the basic idea of vaccination and also herd immunity. So about the immunizing agents, we have the vaccines. So vaccines actually we inject the antigen and it produces the active immunity. And we have also got immunoglobulins and antiserum. And that is actually made up of immunoglobulins is antibodies. Antibodies are directly being injected into the patient's body. So here, because the antibodies enters into his body, the person doesn't have to depend on until antibody is produced by his own immune cells. Like for example, the rabies. After the exposure, if the person we can't, I mean, already the antigen has entered, so now we can't wait for 1 week something, so that the patient's immune cells start producing his own antibody. So in that case, we have to give the ready-made antibody. So the immunoglobulin and antisera will be of that category, and it will be inducing passive immunity. So over the last injury, vaccination is the most effective medical strategy to control infectious disease. I told you, whenever public health comes and infectious diseases, this sentence is very important, that this has been a very effective tool. And smallpox has been eradicated worldwide, and that is because of that vaccine. And poliomyelitis is now in the verge of eradication. Most viral and bacterial diseases affecting children worldwide are now preventable by vaccines. And vaccination is estimated to save at least 2 to 3 million lives every year. So now we have the currently used vaccine. So some are coming under live attenuated. I told you here the organism that is being used, it will be live, but its strength reduced. That is live attenuated. So the most of the vaccines come underneath this. Then it will be killed vaccine. Then the toxoid, the tetanus toxoid, mostly the most important one, and diphtheria toxoid. Then we have the polysaccharide, glycoconjugate, and recombinant. Usually, if at all a question is coming, and I usually put, I think because this is a common way of putting the MCQ, one or the other from these two, because even in toxoid, no one asks these questions: pertussis, anthrax, or influenza. Usually diphtheria and tetanus. So everyone will be remembering diphtheria toxoid, tetanus toxoid. We remember that as like a rhyme. So some question will be coming. One of the question will be from these examples, either killed vaccine or a live attenuated vaccine. An MCQ can come like that. Which category it belongs to? And yeah, another important one that you have to differentiate is oral polio vaccine. So polio is our both the sides. So OPV, if it is live attenuated, and if it is IPV, if you are going to inject it, it is the killed vaccine. Now there is a comparison between killed vaccine and live vaccine, but I'm not going to ask you any question. It is just for you to read what are the benefits. Now, again, I have put over here the immunization schedule in Malaysia. And for your midterm, I have asked this question at birth, which are the vaccines being given. And some of you got it right, and some of you haven't. So please notice it's BCG and hepatitis B. Most of you selected, no, the people who made it wrong, they selected BCG only is given during birth, but no, over here hepatitis B is also given during birth.
Yeah, yeah. If we have the baby book, then we know. The baby book.
Yeah, but
My son's baby book.
yes, yes, that comes out of practice or out of practical knowledge, Lenny. But then, if you had at least put a notice on the chart or the PPT, then you would have understood. Like for those who don't have babies, Farah, how she is going to remember that?
Yeah, yeah. That's a
Yeah,
bonus for us as mother.
yes, that's a wonderful people among you who have kids.
I hope I got it right. I hope I got it right.
Yeah, yeah,
I
you
think
got
I
it
got it
right.
right.
Yeah, you got it right. And I think Farah also got it right. Let us I doubt. Uh, yeah. So it is both BCG and hepatitis B that is given at birth. Now, just the difference between immunoglobulins and antisera, because both are having antibodies in it, and both are inducing, because it is already the prepared antibody that is being injected. What is the difference? It is inducing, both are inducing passive immunity. So what are the difference between immunoglobulins and antisera? So immunoglobulins indicates actually the separated antibodies itself, and that is usually the human variety, the human immunoglobulin or human antibody separated from that. It will be that antibodies alone. It is more efficacious. And here, serum sickness or the hypersensitivity reaction 3. Now, if you go to the earlier classes, the PM, we have learned there is hypersensitivity 1, 2, 3, and 4. And one was usually mentioning about allergy, the acute allergy. And 4 is also acute type of, not acute allergy, but delayed type of allergy or delayed hypersensitivity. And second is usually happening during blood transfusion, when if there is a mismatch of the blood, RBC destruction. And third one is actually serum sickness or hypersensitivity 3. So in serum sickness, it is actually the serum is also used. Serum is that the plasma part of the blood. Uh, Along with that, antibodies, that is the antisera. And in immunoglobulins, it is only the separated, the antibodies alone that is used. So this one, antisera, it can be developed in animals also. Mostly it will be the antibody that is developed in animals. So now this practice is comparatively less. Usually, the animals in which it is induced or produced is horses and rabbits, mostly horses. So, in case of snake poison, how do they produce that immunoglobulin? Is they take the poison, snake poison, and inject it in horses. And I don't know the exact reason, what is that, but horses are naturally immune to snake poisons. Why? What makes them naturally immune? I don't know. Maybe I had to go. But and they induce this snake poison, and the host will produce antibody against this snake poison. And those and that antibody, that the antiserum is taken and then stored. So when a person is going to the health facility or hospital due to poison, the snake poison, the antisera thus produced from the host is usually injected in his body. Of course, we can't put the snake poison in a human being and then take his antibody. That's not possible. The person is going to die. So usually antisera is the serum containing antibody, not just the antibodies, but even the serum. And you produce from the animals. Immunoglobulins is usually the human origin. And if you are going to use anti-serum, it can produce this hypersensitivity type 3 or serum sickness later. Initially, the antibody will be killing that concerned antigen, but then it can produce a hypersensitivity reaction. The body will be, the immune cells will be getting alert. Oh, this serum, it is not belonging to our body, and then the reaction may come up, resulting in a serum sickness. But because immunoglobulin is not having any serum and it is also human made, the hypersensitivity is rarely happening. You can say mostly it doesn't happen. So, though both are having antibodies and both are inducing passive immunity, the difference is like what is the content. One is having only immunoglobulin, that is human origin. Another one is also having antibody or the immunoglobulin plus serum, and that one is produced from the mainly animal. And in immunoglobulin, because there is no serum, solely the separated pure antibody, the serum sickness or the hypersensitivity type 3 reaction is not possible. But in the anti-serum, serum sickness is possible. And sometimes, earlier, the person may even die because of serum sickness. He may not have died because of the earlier disease, but because of the serum sickness, he could have, or some chronic complications might have developed in him because of this antisera. So that risk is not there with the immunoglobulin. So yeah, what we are doing here was, this was the main heading, how to prevent and control. So the first method is vaccination, and yeah, all this comes under the vaccination. The first being the prevention and control. Any disease, any infectious disease we are mentioning in PSR, we have to mention about the vaccine, the concerned vaccine. Then we just went into the different types of vaccines, the schedule, the differences. Now the second what we say for the prevention will be the hygienic practices. So over that, the regular hand washing with soap and water, the proper sanitation, even the clean water, and also now we can remember the sanitary well, the sanitary latrine, the proper disposal of sewage, everything should come under that. Um, and also food safety measures, proper food handling, storage, and preparation. That is also very essential to prevent the foodborne illnesses. So the second one will be hygiene practices. Third one, the public health campaign, or rather health promotion, health education. All these comes under that. Whether it's community engagement, even the community understand what is the importance, why they are doing this. If we are not able to convince a group of people, like a particular area, there is a outbreak of cholera. Just suppose now we can easily advocate, but if those people they don't even know about cholera or how it is being transmitted, and they continue use that insanitary methods, so the contaminated water. the disease is going to get sustained for a longer period in that area. So any public health thing, if we want to make it effective, there should be a community engagement. Otherwise, it is not going to work. Even when COVID-19 came up, people were saying to use mask regularly, to use sanitizer, and if the people were not complying, it is not possible to stop its transmission. So community engagement, their participation is very much necessary. And then also via this public health campaign, we need to encourage vaccination. There is nothing in public health leaving vaccination. So whatever I told, just put a picture of that. The fourth method for the prevention and control will be isolation and quarantine. Now you know what is isolation and quarantine, the difference between that. Isolation means the person is already infected or affected of that disease and we are isolating him. And quarantine means he is not having disease now, but he was exposed to a person who was having a disease and he may have the risk of developing the disease. So, in case of isolation, we are isolating that patient until he is free from his symptoms. And also, if it is the disease organism is transmitted or excreted via the feces, then we make him wait or isolate him until that time uh, the risk period of this transmission until that stops, isolating him. And in case of quarantine, the person is not having any disease or symptom. It is a well or a healthy person, apparently healthy because we don't know, but he had got exposed to this disease factor or the risk factor or the patient. And then we are going to keep him separated from the general population until the incubation period, the longest usual, not longer than the longest usual incubation period. So we know if the organism have entered into his body, within these days, he is going to develop the disease. So we will isolate him only until that period. Like, for example, chickenpox. Chickenpox, the incubation period is usually told 10 to 14, but may extend up to 21 days in some case. So if we are going to keep a person in, we don't know whether he had chickenpox or not, but he got exposed. So we need to keep him never more than the longest incubation period. The longest incubation period for chickenpox was 21 days. So just if he should be made maximum of only within 21 days, but never more than that. That is quarantine. So understand that the difference between isolation and quarantine. Isolation is for those infected persons and they are prevented until the time they are transmitting the disease. Once they are free of their symptoms, we can allow the patient to move about. Even like in typhoid, the person may be during, the symptoms may be reduced, but even during his convalescent stage, there is a chance that his body is discharging the Salmonella typhi. So he is transmitting the disease even when he doesn't have any symptom during that convalescent stage also. So we can't set him free or allow him to go to his family or to the society during his convalescent stage. We know he doesn't have any symptom, but still his body is capable of transmitting the disease because the organism is still discharged via his stool. So that is isolation. And in case of quarantine, it is until it will be a apparently healthy person, but he was exposed to that disease causing factor. And then we are making him separated until the longest incubation period, never more than that. So in case of COVID-19, we usually saw it was coming around like 2 to maximum of 7 days. So the person had to be in isolation initially. Initially, when it came, it was 15 or 16 days around, but then it gradually decreased. Then it was 5 days, then it reduced to 3 days, like that. And no one started giving any importance because the herd immunity by that time have developed. So that's the basic difference between these two terms, isolation and quarantine. The fifth one is vector control, the elimination of breeding sites using insecticides, our five protocols, the chemical, the biological, then what was that, integrated genetic methods, environmental control. So these are the five methods, starting from the vaccine, the hygiene, public health campaign, isolation and quarantine, and lastly the vector control. The five different approaches that we can do for the prevention and control of communicable diseases. And then about the homeopathic prophylaxis, we have already dealt this in some other PPT, I think section 15, but I just thought I will keep a few slides over here also. So homeopathic prophylaxis is the use of potentized remedy in a systematic manner to prevent the development of a characteristic symptoms. It instills actually the natural immunity so that the vital force will be very strong. So even if the disease factor is introduced into our body, the vital force will be able to react with it, and I mean it will be already primed with mild or asymptomatic version of the disease so that it can act against the main disease also. So homeopathic prophylaxis, it gives that natural immunity. The idea or the concept was first introduced by Samuel Hahnemann in 1798, 2 years after to Edward Jenner's famous smallpox vaccination. And in aphorism 73, Hahnemann describes how successfully he used belladonna as a preventive in an epidemic of scarlet fever. Now, we will say about homeopathic prophylaxis, we are never going to forget about the genus epidemics. Like whenever there is an outbreak, we take the common symptoms or the totality, and it may not be suiting like the individual remedy for each individual persons, but we take that common symptoms, the which we saw in the a lot of people or whomever had that outbreak, the symptoms seen in them, those common symptoms, and we select a simillimum according to that and what is called as the genus epidemics. So different epidemics of the same disease didn't always have the same genus epidemics, and occasionally an epidemic had more than one genus epidemicus. And more recently, another method is to use the nosodes. They are useful in the early stages of an outbreak before the genus epidemics has been identified. Now, vaccination versus homeopathic prophylaxis, what are the drawbacks and benefits? Mainly the drawbacks of vaccines. Benefits we know because we are going to save the life, mortality, morbidity being reduced, the socioeconomic status being of the country being developed, not developed, but improving, uh, and the disease being controlling, but it is associated with drawbacks. There is no lifelong protection, which we all know, maximum will be 10 or 15 years. Uh, Lack of safety testing. For example, whenever we say about the vaccines, whenever we have to check according to the allopathic principle, they say the gold standard. Now we have done epidemiology, we have done the different type of studies, the cohort study, the case control study, and though when we are doing all these, the cross-sectional studies, when we saw that, if you remember that triangle in which we keep each study from lowest ranking to the highest ranking, we have done that the gold standard will be RCT or randomized controlled trial. So when it is allopathic, what they say is RCT is very much required. And in RCT, randomized controlled trial, there should be a control group. So when they are introducing a vaccine in the in a community, I mean for the first time, they have already done the RCT, and in RCT, a control group was used in which there was no disease, and then they are injecting that vaccine or testing their vaccine, and that is completely unethical. That is one of the drawback they have told. Then sometimes it can be a manipulated data. We don't know, a false data. false assumptions might be the it may not be effective, but because of the pharma company or something, they make it a false data, manipulate the data. Then side effects, because we know that. Then strain replacement. In case of COVID, we have seen that nowadays also they say even the vaccines we have taken, all the other after effects, yeah, there is the. But then also when a new strain it comes up, they say the vaccine we took will not be efficacious in this strain because this strain is a newer one. So that risk is always there. And the another one is vaccine infection. Sometimes because of the vaccine that can induce an infection. So that is seen in pertussis and most importantly polio. Because in earlier slides, one of the slide when we were saying about vaccination, I told that um, smallpox has been eradicated and polio is on the verge of eradication. But the problem is, it is on the verge of eradication, though we say the one strain of vaccine that is used for controlling for poliomyelitis, that particular strain can induce polio in some of the cases, not everyone ever, but in some cases they can induce a polio. So even the vaccines they have after so many years the research they have found out this particular strain can result in a polio induction. But they're still not able to withdraw that from the market because unfortunately that strain is the most effective also. That strain is that type, the vaccine that is developed from that particular strain is most effective in controlling polio. So they can't withdraw that. But in some people, it can result in polio also. So it is like a double-edged sword, we can say. So vaccine infection is also another drawback. So when compared to that, homeopathic prophylaxis, its benefits that has been explained by Dr. Isaac Golden. So when I was going through, I saw this. So here you will get the link from where I took this content. So the homeopathic prophylaxis, this Dr. Isaac Golden from Australia. He is the present day authority on homeoprophylaxis and the author of the largest long-term study into its safety and effectiveness. So he has got his own set of homeoprophylaxis and some studies done on it. And he says that according to what he had done, the long-term study, what he did, the reactions occurred in less than 2%. And the reaction was never toxic and the person was not never contracting the disease from the remedy like what we told in the vaccine infection, vaccine inducing the infection, that was never happening in case of a homeopathic prophylaxis. And he says even if the reaction is happening, because he told about 22% reaction is happening, just let it we wait it without any interference. uh, but if the reaction cannot be endured, always go for the antidote. Uh, so according to Dr. Isaac Golden, there is much clinical evidence. Clinical trials has been there, but he has not done the statistical analysis. So that becomes a drawback. And actually he had done the clinical study for 15 years, uh, 3 groups of 5 years, like that he had done into some children who have used his own program. But even that, there was an absence of a control group. So no statistical analysis done and also no control group. So that can question the validity and the rigor of his study. But still, when we think we go for actually whether the patient was cured or developed the condition, so that shows his method was effective, and his research findings also showed that the long-term health benefit of following this homeopathic prophylaxis. It suggested an inverse association between homeopathic prophylaxis and asthma eczema, allergies, and behavioral problems. So people, or the kids who were using homeopathic prophylaxis, they had less chances of developing asthma, eczema, and allergy or behavioral problems later in their life. So this one you can go through later. I'm not going each one, but here you can see what is his method of giving homeoprophylaxis. In the first month, giving pertussin and the doses. Second month, pertussin, the doses. So you can just go through his method. So this was the study he did for in 3 groups of people, and not 3 groups for 5 years. What was the method? Yeah, 3 group of 5-year children. For 5 years, he did the study. So he says this is effective, but that is what he's told. There was no control group and there was no statistical analysis being done. We can go through later his method. Then another one was for a set of disease, the influenza, whooping cough, etc. The medicines belonging from um, our central remedies or the main remedies, and then they had a set of nosodes. So in case of influenza, I'm just reading one influenza for the sporadic and epidemic conditions. We always go for eupatorium and gelsemium, and the corresponding nosode will be influenzinum or oscillococcinum. So again, you can go read what were his prophylactic remedies. And it is being continued here, especially for travelers going into those endemic areas, cholera, dysentery, malaria. So in case of malaria, what he says is natriumate 200 if they are going into some endemic area. 1 into fortnight while traveling, plus 1 dose before leaving and 2 after returning. Similarly, Syncona 200C. Nosode, but he had not maybe malaria and amorphisian. I don't know which nosode he means by that, but may not cover all strains. So he has got his own set of prophylaxis. Yeah, you can go through it. I felt it interesting, that's why I put it over here. So now we go to the protozoal diseases. Here I don't have much to explain. So we have the protozoology and helminthology, and in protozoans we'll be learning about amoebiasis and leishmaniasis. And helminthology we do ascariasis, hookworm infection, dracunculiasis, teniasis, and hydatid disease. So the life cycle, when we say about the life cycle of the parasites, we say direct and indirect. Direct means it will be completed in one single host. Example, hookworm and Entamoeba histolytica. Um, and indirect life cycle means they need more than one host. So there will be an intermediate host for its development. So for Plasmodia, they need that Anopheles mosquito, Leishmania, Taenia, etc. So starting with the amoebiasis, which is caused by Entamoeba histolytica. So the term amoebiasis has been defined by WHO as the condition of harboring the protozoan parasite Entamoeba with or without clinical manifestations. And if it is amoebiasis, it can be of 2 varieties, the intestinal amoebiasis and extra-intestinal. If the only intestinal symptoms are produced like abdominal pain and also diarrhea or dysentery, that will be the intestinal amoebiasis. And usually this amoebia can be affecting other organs also, then it will be extra-intestinal. So that includes the liver abscess, lungs, brain, spleen, skin, etc. The agent factor organism is an entamoeba. Reservoir of infection is man is the only reservoir, and source of infection will be the feces, which contain the cyst of entamoeba. The host factors, the person, I mean, at any age it can be affecting. There is no sex or racial difference. Environmental factors will be more closely related to poor sanitation and socioeconomic status, obviously, because it is a fecal-oral route. And if it is a fecal-oral route, it shows that the sanitary or sanitation level in that community is much reduced. which is in turn another indicator about the socioeconomic status. One another reason could be the use of night soil or the feces for agricultural purposes. If it is not been treated, and if the feces is having all these ova, cyst, etc., that may get attached with that vegetation. And when the person is having that vegetation, it may not be that is he ate the food exposed. That was all okay, but maybe he was having some kind of lettuce, which was um, because of this manure. We can't say manure is actually not having. We have seen the composting, and that we have seen that in that heat process, actually all the worm cyst will be dying, so it is safe. But if that is not done, if it was not properly compost made, and if it was simply used, or it was simply put in the river, and that river water is used for the vegetation purpose, then this may stick onto that leafy vegetable or something. And if we are not properly cleaning it, the person may get the infection. So amoebiasis usually comes by that, the fecal-oral route, but it is also possible by sexual transmission, especially between male homosexuals, and also vectors like cockroaches can transmit the disease things, or flying between the feces and the foot. Incubation period is 2 to 4 weeks or longer. So this will be the life cycle. In this parasitology, you need to know about the life cycle. And I didn't keep life cycle in detail because that is going to lag the class and also make the class boring. So I just put the pictures, and these pictures are actually self-explanatory. So we start with the feces, in which the cysts are there, or trophozoites are there. Trophozoites will be killed very soon. Within few minutes, the trophozoites in the um, feces will be killed, but the cyst will be saved for a longer time. And somehow this cyst is getting via the contaminated food or water is entering into the human being, and mostly it will be in his intestine. It is going to grow. The different stages will take place, and then after causing the intestinal amoebiasis, the related intestinal or GIT symptoms, these organisms can spill open to uh, liver, lungs, or even the brain, resulting in abscess. Um, so that will be amoebiasis. Regarding its prevention, primary prevention will be sanitation, safe disposal of the human excreta, washing hands, water supply without the fecal contamination. So here you need to mention something about the sanitary well, or even at least that sentence. We have already learned that the water source and the area of contamination, or the if there is a toilet, there should be a minimum gap of 15 meter or 50 feet. That should be maintained. You can put that sentence. Then the fecal cysts are not killed by chlorine. So chlorination is not going to work, but here it will be removed by sand filters. So in case of amoebiasis, when we are ensuring that water is safe and wholesome, it shouldn't be only chlorination. Before to that, we need to do the water filtration and also boiling. That is more effective than a chemical treatment. Then food hygiene. The second condition is leishmaniasis, which is actually caused by the bite of female phlebotomous sandfly. And we have actually 6 varieties of leishmaniasis: the Kala Azar, or the visceral leishmaniasis, cutaneous one. And if it is the ulcers, if it is produced in the mucous layer also, mucocutaneous junction, it is called as mucocutaneous leishmaniasis. Then anthroponotic cutaneous leishmaniasis, zoonotic cutaneous leishmaniasis, and PKDL, or post-Kala Azar dermal leishmaniasis. Out of this, 4 and 5 is not that important. I just put it so that you know that there are those varieties. But in case if it is asked for exam, You need to remember only 1, 2, 3, and 6. The colors are visceral leishmaniasis because here the affections will be mostly of the viscera, that is spleen and also liver. Hepatosplenomegaly is going to occur in visceral leishmaniasis. And kala azar, I don't know whether you remember, there may be a black discoloration of the skin. That is why in Hindi, this is more commonly seen in India, the kala azar. And kala in Hindi, it means dark or black. So if it is visceral leishmaniasis, it causes that black discoloration with hepatosplenomegaly. Then if it is ulcers in the skin, it is cutaneous, in the mucocutaneous, and also sometimes after the kala azar, post kala azar, some dermal skin lesions may appear, and then it is called as PKDL. So just remember at least the 1, 2, 3, and also the sixth one. 4 and 5, even if you forget, no issues. The agent factor, it is caused by different varieties. Leishmania donovani, it causes the kala azar. Cutaneous is caused by Leishmania tropica, and mucocutaneous, it is caused by Leishmania brasiliensis. You need to remember it, maybe asked for MCQ. Reservoir, variety of animal reservoirs are the dogs, jackal, fox, rodents, and other mammals. But in the Indian variety Kala Azar, man is the only reservoir. Source of infection, usually due to the bite of phlebotomous fly or the sandfly, and that too female one. Then if it is Kala Azar, it is due to the bite of Phlebotomus argentipus, and if it is cutaneous, due to Papataceae and Sergendi. No need to remember, I just put it over there. So this is the typical visceral leishmaniasis. You can see the black discoloration, extra black discoloration of his skin, of his extremities, and then the swollen abdomen because of the hepatosplenomegaly. And this will be the cutaneous and the mucocutaneous leishmaniasis, where there is punched out ulcers. And then when we are going to examine, we see this, this will be the microscopic finding, where we see black colored one, which is the Donovan body, so the organism. You can see that. It's one particular form, a mastigot form. That is what we see. Incubation period is 1 to 4 months, or ranging between 10 days to as long as 2 years. Colors are, as I told, fevers, splenomegaly, hepatosplenomegaly, and darkening. Cutaneous, there will be painful ulcers, and if it is appearing in the margin of mouth and nose, it is mucocutaneous, and then it can mutilate the face. So the stage here will be, there is a sandfly stage and also human stage. So we will start. What is number 1? Okay. So actually the organism, now the phlebotomous, we start from that because it is the bite of the phlebotomous sandfly. So inside the proboscis, where the structure that the fly used to bite the human being, the proboscis, the organism will be present over there, and that organism, Leishmania, will be in the form of promastigot. And when they are biting, this will be phagocytosed by the macrophages. And then in the human being, they will undergo change. The promastigot will be converted into amastigot. And this is the amastigot is actually the Donovan body, which we see in the microscope. And then it will be from amastigot multiply in cells, and from there it get released, and it comes, I mean, it will be present in the circulation, and when the another phlebotomous fly or the sandfly is biting this infected person, this amastigot form will enter into fly's body, and then in his body, in the intestine, this organism amastigot will be changing into promastigot. So the change, what you see is, in case of amastigot, there is no flagellate. It is a non-flagellated one. But in case of when it becomes a promastigot, you can see a flagellae is being produced. That's so many differences are there, but the basic one difference that you can remember is in case of promastigot, there will be a flagellae that is being produced. And because now it is having a flagellae, they will be moving towards the mouth area uh, of this organism, I mean the sandfly, the proboscis area, and then it goes bite human being, the cycle continues. So you can, for the life cycle, just follow this picture. I didn't put in detailed how to do that. But I hope it is not that confusing. It is self-explanatory. If we follow this picture, we'll understand. Just go like that only, as simple as possible, not to complicate it. So the host factors, colors are can appear in any age, but usually it is seen in children 5 to 9 years, and infants below even the age of 1 year, they can be having this kala azar. Males are affected twice than female, and socioeconomic status is highly related. Kala azar is usually a disease uh, which is seen in the poorest of the poor. Poverty increases the risk for kala azar. Poor housing, domestic sanitary conditions like a lack of waste management and open sewerage that can result in sandfly. Now, if you remember the previous slides where we studied about the vectors, sandflies, we have seen that they are mostly seen in the house crevices and then in the cattle shed and all, if it is kept nearby to home, the easy access is there. And also people who are lying on the floor, they have more chances to get bitten, sleeping outside. So these people, and why people need to sleep outside, either because inside the home it is overcrowded, or it may be too hot, or yeah, this might be the reason they prefer to sleep outside. And these are happening or overcrowding, or if it is hot means the facilities inside the house is very less. So that is why we say poorest of the poorest. Just because they are poor, they are not able to afford a better living condition or a better housing, that results in this kala azar. Malnutrition is another reason, especially protein energy malnutrition, iron, vitamin A, and zinc deficiency can result in this infection or increase the risk of infection. And people who are involved in farming, forestry, mining, fishing have the risk of being bitten by sandflies. And if the person is recovering from the kala azar, it gives a long-lasting immunity. And control measures is there is no vaccine. So we have to do three methods or three approaches. First one is control of reservoir. And we already discussed in case of Indian variety, because this is most commonly seen in India. Man is the only reservoir. So we don't have to worry about other organisms. There are other animals which are responsible, but mostly because this is commonly seen in India, and in Indian variety, it is the man that is the only reservoir, which means we don't have to bother about other organism, how the cycle is going on. We need to be very careful with only the human beings. So we have to find out the cases who are having the disease, early diagnosis and treatment. So that is what here we are going to do. So we need to do the active and passive case detection. Now, do you remember what is the difference between active and passive case detection? We have dealt this condition. I mean, we have dealt this. What is active and passive case detection? Or active and passive surveillance also. You know what is the difference?
Um, uh, the active is to get to know the case earlier before the patient is presenting the symptoms. or try
Yeah,
to
yeah.
detect before.
High risk, right, for active?
Yeah, active means just think about ourselves. Like we are epidemiologists or a public health researcher, or we are into the public health managers. Imagine active means we have to become active. That means we are not sitting in the office. We are going to the community. We are going house by house. We are screening the people, and we are doing our work. That is active. We can't sit idle over there. We have to get active into the community and find out the people who are having the disease. Or even before, like sometimes in their family, we go to one house, we see that one of the patient is having. So we regularly follow up to see whether the other person is developing, or because one patient is already there means the risk factor is present already. There is sandfly that is present. So what are the things we can do? So that becomes active. Well, we are active, not the disease. Always remember the active surveillance, active case detection. When those terms come, remember not in the disease way, but from our perspective. Like we are the public health researchers, and we have to get into work, actively involved, go to the community, find out the cases. So we can go for house to house visit, mass survey, screening, anything. That is active case detection. We are becoming active, not sitting in the office. But when it is passive means we are not doing anything. We are just sitting in the office and the patient is coming with the symptom. So there is only slight change in what you told. When the symptoms are coming up, the patient is coming to the clinic. Then we get to know the medical officer should actually report this condition, and then even he's reporting means the epidemiological uh, survey or that office, they get the details. Every week they will be phoning up, or they don't have to phone up. That's a governmental policy or governmental arrangement that such notifiable diseases have to be reported. So every week, if it is not a outbreak or something, every week they will be giving a list from the hospitals. These diseases were reported over here. So sitting in the office, the researchers or the epidemiologists, they get the details about the case. So that will be passive surveillance. So this word actually, rather than from the patient perspective, remember from our perspective. Whenever we have to actively go out to the community and find it out, that is case detection, active case detection. We get into the community. And passive is we are not doing anything. We are just sitting in the office and cases are being reported to us. So both the method have to be done. The active and passive case detection, both should be there. It is not that passive case detection we have to give less, or active we have to give more. Both have importance. Then sandfly control, because the next possible after we do with the reservoir, that the persons are is earlier diagnosed, they are treated so that they don't even go to the PKDL level. So we need to do with the persons, the man. And for the sandfly, we can go for the chemical method, the DDT is the first choice. And then all the other environmental measures, eliminating the breeding place, location of the cattle shed, housing, proper housing, general sanitation, and then the personal prophylaxis, that is using the repellents, the nets, etc. Then in helminthology, we'll be studying the soil transmitted helminth. The first one will be ascariasis or the roundworm, which is actually caused by Ascaris lumbricoides. And then we have the vague symptoms like nausea, abdominal pain, and cough. And sometimes it may also result in intestinal obstruction. Ascaris is the most common helminthic infection, and it is estimated that worldwide annually about 1 billion people are being infected. Reservoir man is the only reservoir, and infective material will be the soil, which contain the feces, which is infected or contaminated with the eggs. Host high rate in children, and they are the most important disseminators of infection also, because they don't keep their when they are playing, they will be playing in the soil, playing with the soil. more than that, the problem will be they won't be cutting their nails and all, and then the worm can easily penetrate and enter to their body. Roundworm rob man of his food, especially vitamin A, compete for vitamin A, and it can also result in malnutrition. Then environment, ascaris is soil transmitted and they are mostly seen in clay soils. And when we do that, in case of hookworm, it is the porous soil which is suitable for hookworm and clay soil for the growth of the ascaris one or the roundworm. So regarding their life cycle, so from the feces, which is contaminated of the fertilized egg, it reaches, open defecation or somehow it is in the soil now. So if it is unfertilized, it may contain both. It is not going to undergo further development. So forget about it. The fertilized egg, if the feces is having the fertilized egg, it will go through different stages. You can see the embryo that is undergoing different changes, and somehow this is entering into the human being because it is mostly the fecal-oral route or the soil via the fecal-oral route. The organism enters into body, and in the intestine they will be undergoing some changes. And once in intestine, when they are developing the embryonated egg, after entering the intestine, it will be hatching into larvae, and then they will break open this mucosal area of the intestine and then will migrate into lungs. From lungs, they may cough up and again swallowed. If it is because it is mostly seen in children, so the larvae, when it reaches this lungs, they will be having cough related symptoms, and these kids are never going to throw that expectoration out, mostly because of their difficulty or their laziness. They tend to swallow it back, which means the larvae enters again to the stomach region, and then the maturation proceeds in the small intestine. So this is the way the life cycle is happening. And only one ascari or roundworm enters the body, it can then multiply into numerous number. Regarding their control and prevention, we will be doing after we do all the soil infected worms condition. So the second one will be hookworm infection. See the difference of sandy soil and clay soil. So clay soil mostly for the ascaris, and the sandy porous soil, it will be for the hookworm. So this hookworm means which is caused by Ancylostoma duodenale or Nicata americanus. Here also man is the only reservoir. Infective material is the feces. This is the immediate source of infection. Or rather the soil, soil which is contaminated with this feces. Age and sex, the highest incidence is seen in 15 to 25 years. And higher prevalence seen in agricultural workers. Then environmental factor, it is most commonly seen in damp, sandy or friable soil with decaying vegetations. Or the sandy soil is more favorable than the clay soil. And for them, the development will be like the organism or the in the feces, the egg will be present, and that will go undergo the change, and it will be converted into larvae, which is called as the rhabditiform larvae. And this development will happen in the soil, the external environment. And when the person is walking barefoot, that is why agricultural people are more affected, and also that particular age 15 to 25. So when they are walking barefoot, this filariform larva that will be penetrating the skin, and they will be moving towards the, and this can also happen, they are entering via the this one, or even the fecal oral route. Even the fecal oral route, it enters, then same similar to what happens with uh, roundworm. The same is happening over here. It is developing in the small intestine, and then it will be moving out to the lungs, coughing up, again coming to the stomach. So the same cycle, similar cycle is happening here also. So in individual, the hookworm infection can result in iron deficiency anemia. And then iron deficiency, if it is happening in expectant mothers, it can result in high morbidity, low birth weight or preterm baby, abortion, stillbirth, impaired lactation, etc. And even can cause hypoalbuminemia. So that is the effect of the disease in individual, because mainly because of the iron deficiency anemia it causes. And in community wise, the effect will be, it is going to affect the growth, development, nutrition, work and productivity of that entire community, and also medical care cost. So prevention of this the soil control one. The primary prevention is what we do: the sanitary disposal of human excreta, providing safe drinking water, maintain food hygiene, and of course the health education. And health education, we need to teach them about the importance of sanitary latrines, that is no open defecation, to maintain personal hygiene, washing hands before to or after definitely after coming from toilet, and before eating, before cooking, the importance of that, changing behavioral patterns, uh, start not to walk barefoot, uh, and making use of health facilities for diagnosis and treatment. Then in case for them, these worms, they have the medicine therapy. So according to the WHO strategy, they go for the periodic deworming, especially for the people at risk in the endemic areas. And at risk, there will be preschool children, like from 1 to 5 years, school children, and women of childbearing age, because if it is affecting, we saw IDA or iron deficiency anemia is one of the most important one. So even those women, they are at risk, and adults in certain high risk occupations. So then the WHO recommends the treatment. I didn't put the dosage or the name of the medicines, but the deworming medicines. If the prevalence is over 20 percentage, then WHO recommends the deworming once a year. And if the prevalence is over 50 percentage, then it is twice a year, according to WHO. And this periodic deworming we can integrate with child health days, supplementation program for preschool children, or with other school health programs. So when that madam or me, I don't know who will take, when we'll deal with school health programs, you can see that even deworming medicines are also given to children during the for the school children during the nutritional days. Somehow it is being given. Then another condition, protozoal condition, is dracunculiasis or guinea worm disease, which is caused by the nematode Dracunculus medinensis, and it's usually seen in the African countries at present. It is only present in these countries. So here the agent is actually the organism, the Dracunculus medinensis. Okay, we'll go to the life cycle actually. So, in case of the dracunculus, what it happens is uh, two ways it can enter into the human being, like contaminated water, because this dracunculus, it is actually getting inside the cyclop. And if the person is having, how it enters cyclops, we'll see. But if the person is drinking water uh, that is having that cyclops, it enters into his intestine, and inside the intestine, this cyclops will be breaking open. The organism, the dracunculus, comes out, and it will be growing and developing. And once it is developed, when the mating happens, the male and the female, the mating happens, the male organism will die, and the female, the gravid female, will be moving towards the leg region, the distal part, the foot region, and then it will go and lie under that foot. the foot that tissue over there, underneath that skin, and it will take around 1 year. It will be then that area will be converted into a blister, and the person will be having intense burning because of this blister, and he will prefer to expose his leg to in water. If it is a small confined water and properly disposed, that also is okay. But mostly what happens is earlier this disease was a risk because step water or step wells, not step water, sorry, step wells. And I have kept that picture when we were dealing with the wells. So the step wells were one of the most important risks for this disease. So when the step wells were there, people will be with this infection because of their burning nature. They will be going and immersing their feet so that they get some amelioration. So when the blister is coming in contact with water, the blister will break open, and the larvae, the worm, will be coming out in this water. And this water, I mean this organism, will be taken up by some cyclops. And within the cyclops, the further changes of the larvae will take place. And when we are consuming this water in which the cyclops which are infected is present, as I told, the organism enters. And once it enters our body, the cyclops will get disintegrated, but the worm will remain. So another method will be the cyclops being taken. So one way we can say is the cyclops. If you remember when we were doing the cyclops, its control, I told that there is no much problem to prevent the cyclops. Only boiling or even straining the water is enough for the cyclops to get destroyed. So if the person is doing that also, the second one is if the cyclops is taken in by fish, and then we are going to consume it, not properly cooked or undercooked fish, that also can result in the same cycle. So that is how Dracunculus. So now we go back. So here we see the gravid female makes its way down to the infected person's lower limb. I explained you how it is coming. Once the development takes place, it moves towards the leg area, and then it penetrates to the dermis and induces a blister formation, which will take approximately 1 year. And when it comes into contact with water, the blister ruptures. The parasite is released, up to 1 million microscopic free swimming larvae. And this will be picked up by the cyclops. And man acquires infection by drinking water containing infected cyclops. And the host factors, the habit of washing, bathing in surface water, and using step wells is an important mode of transmitting the disease. So the guinea worm disease is totally water-based disease and does not have an alternate pathway of transmission. Why I gave this importance is so we take care of the way in which the water transmission is not happening means we can control the disease, and that is why it is amenable to eradication. So we have to give them provision of safe drinking water, the pipe water or installation of hand pipe, so that the people don't have to go to river. Even then they go for their leisure purpose, means they have to be careful. Control of cyclops. And for control of cyclops, just a simple straining will be enough, or even boiling. And health education, saying them not to use when there is a blister condition, not to go to the water, boiling the water, sieving the drinking water, um, personal protection and prevention of water contamination. And also surveillance is also required. 1 minute. There is hydrated also. No. Okay, 10 more slides are there. Can I do it? Can I finish it?
Yes.
Yeah, okay.
Okay, I'll just finish it up. So in case of teniasis, the tapeworm, we have Taenia saginata, Taenia solium. And Taenia saginata, these diseases or teniasis or the tapeworms, it is also called as cyclozoonotic disease. because they need more than one vertebrate, but not in no invertebrate for their development. Maybe for MCQ purpose it may come. So teniasis actually causes two type, intestinal teniasis and also cysticercosis. Actually, intestinal teniasis is not a problem. It is the cysticercosis that is going to cause a problem. So in the teniasis, we have two varieties, saginata and solium. The larval stage of Taenia solium, which is also called as cysticercus cellulose, it can result in cysticercosis. Some cyst condition is being formed in especially the muscles, eyes, and cerebrum, and that can result in complication. That is the main problem with teniasis. So Taenia saginata, the definitive host is man, and the intermediate host is, in case of saginata, it is cattle, and for solium, the intermediate host is pig. So as I once mentioned in practice of medicine, you need to remember this, which is the intermediate host for saginata and also solium. So sol, you can connect the sol is usually that word used for indicating pigs. So from that you can connect like that. Um, the definitive host and intermediate, I don't know whether you remember the difference. Definitive host means it is in those hosts where the sexual cycle is happening or sexual reproduction of the organism is happening, and the asexual cycle happening, that organism, it's called as the intermediate host. So how this is transferred is the mode of transmission through the ingestion of infective cysticerci in pork. If it is not well cooked, if it is pork or the pig, Taenia solium, we get the infection. Or if it is the undercooked beef, it will be Taenia saginata. But in this, we will have the intestinal teniasis. But if you are going to ingest the food, water, or vegetables contaminated with the egg, fecal oral route, it is going to produce cysticercosis. This we will understand in the cycle actually. So we go for the cycle. And now this is of Taenia solium. But if we change this organism, like instead of pig, if we keep the cattle, it will be Taenia saginata, matching for both. So what is happening is two cycles are happening. One is teniasis and the cysticercosis cycle. So here what happens is in the stool, the organism, the eggs are present, and somehow like maybe due to opification or something, this organism from the feces now got stick on with the vegetation, and that vegetation is being eaten by the pig or the cattle. Then the variety changes, that's all the difference. So now because it is the solium, we stick on with the pig. So pig is happen to eating that vegetation, and in the pig, the embryo, the embryonated egg, it will undergo change and it become oncospheres. And this oncospheres will then enter into the musculature of the pig itself, and it will become a cysticerci. So this change, the oncosphere becoming a cysticerci, that happens within the muscles of the pig, or if it is saginata, it is happening in the musculature of the cattle. And then man happens to eat this undercooked beef or undercooked pig, that cysticerci is entering his intestine. And then it is producing intestinal teniasis. And this intestinal teniasis is not a big problem. Usually it will be causing some mild diarrhea, abdominal symptoms, that's it. But the another cycle possible is this person somehow he is going to his body via the fecal oral route, not the undercooked fish or and undercooked pig or the other one, but due to maybe he is happen to be a vegetarian, you can say like that, and he consumed that vegetation in which the feces were there with this egg. So the fecal oral contamination, if that is happening, then the same changes which is happening inside this pig, that is egg changing into oncosphere and oncosphere changing into cysticerci, that happens inside the human being. So he took in that embryo or the egg, and the egg, it will be converted into oncosphere, and as like in the pig, it will go into the musculature of the human being, and usually it will be in the brain, eyes, subcutaneous tissue, and the oncosphere will be becoming cysticerci. And if this is happening, this condition will result in cysticercosis, and this is the dangerous condition if this is happening. So one type of cycle in which the tinea is entering the human body via undercooked beef or pork is not dangerous. It can cause cytiniasis, some mild symptoms, but the most dangerous is if it is entering via fecal-oral route, because all the changes will then happen in the human being, the oncosphere converting into cysticerci within the musculature. So that is what we are saying over here. So infections can be acquired through the ingestion of undercooked beef or undercooked pork, Taenia solium or Taenia saginata respectively, and that causes intestinal teniasis. But if this organism or this from that stool, that egg is via the fecal-oral route, if it is entering into a human being, it results in cysticercosis, which is more dangerous. So, intestinal teniasis, there may be just abdominal discomfort, anorexia, chronic indigestion, and some cases, extremely rare, it can result in appendicitis and cholangitis. But the most important is cysticercosis, and that too of Taenia solium variety. So when we do have to control, which is the pig, wherever the pig domestication is done, we have to be very careful with the, when we discuss about the prevention. So cysticercosis, which is more dangerous, it is associated with the development of the larval form within a intermediate host. Swine are usually the intermediate host for Taenia solium, but humans, usually the definitive host, can serve as accidental intermediate host. What is mentioning over here is the usual cycle is like this. If it is the usual cycle that is happening, it is not a risk teniasis. But the problem happens when when rarely such a cycle happens. Usually, man is the definitive host. We learned that in the earlier slide. Man is the definitive host where the sexual cycle is happening, and asexual cycle is happening in the cattle. That is the change from the oncosphere to cysticerci that is happening over here. But in this picture, what is happening is this change from oncosphere to cysticerci, the asexual cycle, is accidentally happening in the human being. Usually, it shouldn't happen, or usually this is what happens. But accidentally, when human get infected and the change happens, the sexual cycle happens, that is of more risk. So the cysticercosis is usually acquired from the fecal-oral route only and not via the ingestion of the undercooked pork. And that is, if it is undercooked, usually intestinal teniasis will be resulting. So if it is the cysticerci is formed in the CNS, then it can result symptoms of epilepsy, intracranial hypertensive syndrome, hydrocephalus, psychiatric diseases, or even death. So this will be the manifestation, the neurocysticercosis, and if it is in the eyes, ocular cysticercosis. Control measures, we need to treat the infected person, meat inspection, both the cattle and also the pig, and then give them health education, the ways of transmission and how to control it. Adequate sewage treatment so that the vegetation or the agriculture is not being contaminated with this ova, cyst, etc. The last one in this one category is hydatid disease. This is dog tapeworm, or belonging to the Echinococcus variety. And there are four varieties: Echinococcus granulosus, which causes the most common one, the unilocular Echinococcus. Hydatid disease, the unilocular variety. The Echinococcus multilocularis, it causes the alveolar type, and this one is more dangerous. Alveolar type is more dangerous. Then there is oligathus, which causes unicystic form, and Vogeli, which causes polycystic. You can expect as a MCQ, which variety causes what. And this is usually an occupational disease seen in shepherd, their family, and also shoemakers. Here the human infection happens because of the ingestion of the egg, because from unwashed vegetable, water, and also food, or playing with the dog, because it is the dog tapeworm. So if it, when we are playing with dogs, or inhalation of the dust contaminated with the infected eggs can result in that. And this dog tapeworm or hydatid disease is not directly transmissible from person to person. So here the cycle is actually this one, the cycle is between them, the usual cycle. The red is actually the cycle. So it is actually the organism present inside the dog. That dog is the definitive host where the sexual cycle is happening. And then it is released via its feces. Somehow it is entering via the vegetation or anything, it is entering the sheep, and in sheep the asexual cycle is happening, and it is excreted via his stool. Somehow the dog is getting infected. So this is actually a cycle that is happening within the sheep and the dog. But here, man becomes a accidental host, maybe because of handling with either the dogs or handling with the sheep. That is why shepherds, that they told. So somehow, when we are dealing with them, if this organism or the egg enters into man, then it produces hydatid cyst, or the cyst which is containing some fluid. So that will be formed in any part of the body, like in the bones, liver, gallbladder, lungs, brain. So here in case the symptoms develop very slowly because it is the cyst that is forming, it will take many years, like 5 to 20 years after the entry of the egg. The cyst will be varying from size of pinhead to that of a small football, usually seen in the right lobe of the liver, but also in lungs, brain, peritoneum, long bones, and kidney. The cysts are filled with watery fluid, and inside that fluid there will be many that organism or the tapeworm head. And when if it the cyst is rupturing, that head will be or the root capsules, that's the term used, that will be spilled out, and then they will go metastasize to the nearby structure, and then cyst will be formed there. So even one single egg is enough to give rise to several hydatid cysts. If it is small size, the cyst, it is usually not causing any symptoms, but if it is large cyst, there can be pressure symptoms. Uh, so how we can explain hydatidosis is usually in other manner, like human suffering, then medical diagnosis cost, hospitalization, surgery, man hours lost, and also temporary or permanent incapacity. The retarded growth of animal, reduction in quality and yield of meat, milk, and wool are also very important, which means this disease will be affecting, or we can say its severity only in economic basis. Health wise, it's very difficult to say because mostly if it is small size, it is asymptomatic, and large cyst may produce the pressure symptoms. So, and also it is a long duration one. So, mostly we can say the impact only in economic matter or economic way. Prevention is preventing the dogs from gaining access to raw offal at slaughterhouses. So we have to control the slaughterhouses, proper meat inspection, destruction of infected viscera, and control of dogs, elimination of stray dogs, or having an effective registration system, surveillance of their dogs based on the stool examination, and health education, especially to butchers, dog owners, animal breeders, and shepherds. This will be our medicines for all the parasitic conditions. Out of this one, um, this for Felixmas, granatum, Malotus, and Cuso. This four is mainly for tinea condition, tiniasis. This four. Okay, that's all. Let's just case scenario for the activities. So that's all for today.
Thank you.
Yeah. Second.
Thank you.
Thank you.